when we went through this process last Congress, I was visited by a lot of patient groups who were just concerned that the pendulum would shift, and we use the term chronic pain, people who have it forever, and I want to make sure we don't lose them in this debate, people who wouldn't be able to get out of bed without some assistance. So I do have a statement for the record. Mr. Chairman, I'd ask unanimous consent from the American Physical Therapy Association addressing this. And
without objection.
And because then it goes into my first question for Dr. Mercantz-Katz. In question and answer and some of your comments, you talked about all the components of treatment, which as I'm getting more educated in this process, it seems to me that we're not always considering all the components, or maybe physicians, they may get stovepiped into one delivery system, and every patient's different, every pain issue, and that's kind of where the physical therapists are saying, hey, this should be part of some treatment. So can you, for the sake of all of us, kind of talk about the difference between naltrexone, Suboxone, and methadone, just briefly?
I'll try. Yes, so naltrexone is an opioid antagonist. What that means is that it will block the effects of an opiate. So if somebody is opiate addicted and they're withdrawn from those opioids and then started on naltrexone and then they use an opioid again, they will not get the effect that they were expecting. So it will block them from getting high. So that is the value of naltrexone. It's often seen as a medication that gives a person a chance to get back to counseling because they may relapse while they're in their regular using environment.
Okay, just pushing you, Suboxone.
I'm sorry? Oh, you want me to go?
Pushing you.
Okay, here you go. Suboxone is what we call an opioid partial agonist, and what that means is that it has lower abuse liability and has less potency in terms of euphoric effects.
Okay, methadone.
And does methadone, which is which is what we call a full agonist, and it is a medication that is only available for the treatment of opioid use disorder through federally regulated opioid treatment programs, which my agency regulates.
Okay, let me go to Dr. Shuchet. How does CDC inform evidence-based best practices? So if you're using these three different things, how do you collect that data?
Right, CDC is working to evaluate the medication-assisted treatment and counseling efforts that SAMHSA has right now. So we actually have a study in the field with these different modalities.
So then the information can get out and people
Right,
can
so that we
make
can
better
share.
determinations. Okay, let me go to Mr. Doherty. This will be a friendly question. Category 2 or 3, what's the difference? Schedule, yeah. Schedule 2 or 3 on the drug listing.
Yes, sir. So with respect to Schedule 2, for instance, those are controlled prescription pain medications in the oxycodone, hydrocodone family, and we certainly, they go in a range from 3, 4, and so on.
So what's the difference between a 2 and a 3?
The difference is, sir, that it's more strictly controlled within DEA on the schedule.
Why?
Based on the scientific dependency of...
Okay, dependency, what else?
Abuse liability.
Danger for abuse.
Okay, danger for abuse. Okay, let me go to Dr. Gottlieb. FDA, black box, labeling. It's my understanding there's no communication based upon schedule and what might be labeled. Now, you see where my whole thrust of these questions is more information, more different practices, then that would also go to labeling. If DEA says, Schedule 3 is less addictive, shouldn't that maybe be listed on the label?
I can certainly take it back to the agency. There is labeling language that reflects some of the qualities of the drugs that relate to their abuse potential currently.
Do you agree that there may or, I mean, I would hope that we would talk together and that our agencies would communicate that might give the practitioners a little more information. So, Mr. Chairman, time's expired. I yield back.
I thank the gentleman's comments. It's interesting, in Oregon, I think through the Oregon Health Plan, they actually often give the antidote, naloxone, with the prescription for opioids, which the people in the roundtables I've been in sends a real signal of seriousness about what people are being given to take, the opioids, because here's the antidote because it may kill you.